Greetings. This is Alan Lewis, Dean of the School of Health Professions, and welcome to our first lecture of the new School of Health Professions lecture series on culture. Again, thank you for joining today. I want to say that the idea for this particular project came from several different sources. One, at Downstate, we have a very diverse community, and so the cultural piece is always in our face, which is definitely a good thing. And we need to make sure that our students really understand that culture is something that has to be embraced in providing effective healthcare. So that's one reason. The other thing is that obviously over the last 8 or so months, we've had some unrest in our country over some cultural clashes, i.e. racist kinds of activities that have been underway. And so it seemed like a good time now to really lay out a set of topics that would be useful for our students. So this particular series really is aimed primarily at our students at Downstate, students in all the schools and colleges. Although anyone who wants to attend can certainly attend and take advantage of hearing the information I'll present for the first 30 minutes and then being involved in the conversation for the second 30 minutes. This particular activity will involve a 30-30 format, 30 minutes of basic overview of me presenting some information and then 30 minutes of Q&A, discussion, and engagement. Thank you for joining. I know this is actually happening at 5 o'clock on Wednesdays, so that's after the normal workday. So again, we are appreciative of those of you who've been able to join to have this conversation with us. So our topic today is the concept of culture and why it matters in effective healthcare. And so culture is a concept that most folks feel like they have a pretty good idea of what it means. And generally speaking, that's true. Culture is a concept that most academic disciplines have their own spin on what it means. Many disciplines promote their own cultural definition. Of course, anthropology is the one discipline that is most typically involved with cultural matters, and they do a lot of research on culture, and they sort of claim culture as their domain of primary expertise. But when we speak about culture, we really mean a certain lifestyle, a set of values, traditions, customs, language, basically a way of seeing the world that's synonymous with a particular group of people. So culture really is a subjective reality, or a way that a prism through which one sees the world and interacts with the world. And so culture is both a dimension that unifies those who are within the same cultural group, and it also distinguishes those who are in different cultural groups. So culture both unifies and clarifies those who are different along those lifestyle worldview dimensions. Culture is a concept that's been studied quite a lot. I like the work of Dr. Edward Nichols, who back in the late 1980s, which seems like a long time ago now, put together something called the philosophical aspects of cultural difference. And that's actually presented and published, I think, in 1989. And what Dr. Nichols did was he basically traveled the world and looked at various cultures and tried to basically validate the point that culture does impact worldview, that there are different worldviews, different ways of approaching certain processes based on cultural orientation. So he looked at the philosophical aspects of axiology, that which has value, epistemology, how it is that we come to know things and generate knowledge. He looked at pedagogy, which obviously is teaching, primarily the teaching enterprise. He also looked at logic, the process that we use to arrive at conclusions and think through things. And so he found out that in his field-based work, which is sort of anthropological in how he conducted it, he found out that culture is something that determines how different groups approach these philosophical aspects such as axiology, epistemology, pedagogy, and logic. When we talk about culture in the United States, we typically default to talking about culture as it relates to the one dimension of race. Race seems to be a particular preoccupation when it comes to talking about cultural matters in the United States, and that's for two reasons. One, because of the slavery experience that started in the early 1600s and lasted to just beyond the middle 1800s, was an experience that where those who were enslaved and those who did the enslavement was based on race. So race was a prominent factor in that whole enterprise, and has continued to be a prominent factor since the ending of slavery, since the oppression And the discrimination has continued in this country even up until today, as I said earlier. We're still seeing some activities that are based on race and the bias around race. So race is prominent in our country because of the slavery experience. It's also prominent for another reason. Race tends to be one of the few aspects of culture, one of the few dimensions of culture where one can actually look at somebody and make a judgment about what that individual's race is. Now, the person may not be right in his or her judgment about that person's race, but you certainly can make a decision and guess about what a person's race is by looking at who they are and making certain assumptions. Because race and ethnicity tend to be somewhat visible. Now, there are many other dimensions of culture. Race and ethnicity is not the only one. Obviously, there are things such as sexual orientation, religious affiliation, gender identification, political affiliation. Obviously, if you belong to one party, you have a different worldview from another party in terms of, say, for example, Republicans and Democrats. Social economic status, people who have great wealth and those who are living in poverty certainly have a different worldview. There's certainly a worldview synonymous with, or a cultural orientation, if you will, synonymous with a particular discipline that one participates in. Clearly, physical therapists have a certain worldview, certain set of values and assumptions and the way that they view the world, which may be different from the way a midwife may view the world, which may be different from a physician and different from a nurse. So clearly, discipline or profession can be a cultural orientation as well. The thing about culture is that every individual has multiple cultural orientations. So you have a cultural orientation that relates to your ethnicity or your nationality or race, if you will. You have a cultural orientation that relates to whatever your profession is. You have a cultural orientation that relates to whatever you do in terms of the spiritual realm, if anything. You have a cultural orientation that relates to your socioeconomic status. If you have a political affiliation, that's certainly another cultural orientation. So clearly, culture becomes a multi-dimensional concept within each individual because individuals have many cultural affiliations. And so that makes it somewhat complicated. The other thing to think about is that, honestly, the most important aspect of culture is that each person really lives in his or her own individual cultural experience. So even if you have two people who are the same race, same ethnicity, same religious orientation, they may not be very much alike because those two individuals may have a very different life experience based on their subjective reality and the sum total of the experiences in their life up to the point that you're looking at these two individuals. So the matter of individual culture becomes particularly important, and it really is the thing that we should consider to be the defining dimension of culture. So bottom line, when you're looking at somebody and you're providing healthcare services to someone other than yourself, and you can't do it for yourself, obviously anybody you're providing services for is going to be another individual, and that person is going to have an entirely different set of life experiences than you have as a healthcare provider, and therefore that person has a different culture from you. So even though we have these traditional dimensions of culture, such as race, ethnicity, sexual orientation, gender, spiritual orientation, those types of things, the bottom line is that every person that you come in contact with has a different cultural orientation because that person has a different set of life experiences. So they have different assumptions, a different worldview, a different set of traditions and customs they may be accustomed to. There may be some similarities across people, but the bottom line is no two people in the world have exactly the same life experience. Even two identical twins, who are the two individuals that are the most alike both genetically and socially, because they grew up in the same family typically, even those two persons have a different life experience to some extent. So the bottom line is that even though we look at these traditional markers of culture, such as race and ethnicity, and others, we have to make sure that we understand that each person that we're encountering and that we come in contact with has an individual cultural orientation that's different from us. So that's the bottom line point in terms of understanding culture. Now, why is culture an important concept in effective healthcare? Well, if you think about it, a healthcare provider is trying to facilitate a process in which the healthcare recipient, the patient, the client, or the recipient of services is receiving those services and trying to achieve some different health status. And so you're basically trying to motivate that person to do something different and enable that person through maybe imparting some skills and maybe some behavioral change to actually achieve a different health status than the person has initially. That's the bottom line with healthcare, whether it's PT, midwifery, medicine, nursing, whatever it may be. You're trying to facilitate change in an individual who's come to a healthcare provider for assistance in improving one's health status. And so in order to facilitate change in an individual as a healthcare provider, you have to know as much about that person as possible. And culture gives you all the information you need in terms of that person, what he or she values, what he or she is looking for in terms of the therapeutic process, what the outcome of services would be that person is seeking, and it has everything to do with that person's subjective reality, that person's worldview, and what that person is looking to seek and gain from the healthcare encounter. So there are really 5 reasons that I want to lay out that really speak to the fact that culture is an important concept in effective healthcare. The first reason, effective healthcare requires the clinician to own culture, meaning the clinician has to know his or her own culture, so it does not interfere with the therapeutic process of providing services to someone of a different culture. Because we all know that it's not difficult, and in many cases, our own baggage and the things that are synonymous with who we are can disrupt the clinical encounter if we allow them. So effective healthcare requires the clinician or the healthcare provider to be very aware of what his or her cultural dimensions are, and to ensure that those dimensions do not become barriers to the effective therapeutic process, to basically make sure they don't contraindicate successful services to the person that they're providing services to. Secondly, effective healthcare requires the clinician to have insights into the service recipient's culture, because this insight will speak to what the individual values, the axiology, what the individual prefers in terms of the process of receiving services. So that providing healthcare services happens through a process, and people will have preferences around what that process is. And it speaks to what the individual who's receiving services desires in terms of ideal or ultimate outcomes. We all know that in the healthcare environment, it's, as healthcare providers who are expert in what you do, you may have ideas about what the ultimate outcome is that the service recipient needs to strive for, but bottom line, the service recipient needs to buy into that and needs to basically, maybe not even buy into that, be more self-determining and be autonomous and dictating his or her outcome that he or she ultimately wants to achieve with your help in terms of the healthcare services that you will deliver. So that's very important. Number 3, effective healthcare requires positive communication and rapport between the healthcare provider and the service recipient. And so the more that you as a healthcare provider respect the cultural orientation of the person providing services to, the better you'll have a rapport with that person, the stronger that bond will be, and that therapeutic alliance will be stronger. And therefore, you'll have a higher likelihood or probability of achieving the desired outcome that that person actually wants. Obviously, a person who's coming to achieve change through a healthcare encounter with a healthcare provider helping has a certain level of motivation, or may not have much motivation, but there needs to be some motivation, and motivation can be very much a concept that's embedded in one's cultural orientation. So you have to understand what motivates that person in order to actually have that person to begin the process of changing toward the improved health status. So again, the communication and the rapport between the healthcare provider and the recipient of services is very important, and the extent to which the clinician can be respectful of and not disrespect the cultural orientation of that recipient of services is the extent to which that communication and that rapport be strong. And we know that the single most important aspect of a successful therapeutic encounter in a healthcare environment is the strength of the relationship between the two persons involved in that process, the healthcare provider on the one hand and the recipient of services on the other hand. If that relationship is strong, chances are the healthcare provider can influence the service recipient and facilitate a process that will lead to a more successful outcome, meaning improved health status. Number 4, effective healthcare requires the service recipient to trust the clinician. The extent to which the clinician has built that rapport and has that communication and respects the cultural orientation of the service recipient is the extent to which that trust will be beneficial and will be a positive aspect within that relationship. Number 5, effective healthcare requires a clinician to facilitate important changes in awareness, in understanding, in motivation, and behavior to improve health status. So think about it. If you think about what it takes for an individual to actually change, that individual actually has to have some improved knowledge or awareness about the need for change. The individual has to have some understanding of why the change is important for him or her. In other words, how this improved knowledge and awareness about the change actually specifically impacts that individual. That individual then has to have some motivation to go through the process to engage in the change. And then the individual actually has to have some skills to actually make the change happen, to promote the change. And that's a behavioral aspect. So, and then ideally, that person goes back into an environment outside of the healthcare encounter where those new behaviors and that new awareness and that new motivation are supported, and that continues, that new behavior continues, and so the health status is improved. Now that's in the ideal situation. A lot of times folks don't go back to an environment or context where that motivation and those behaviors aren't necessarily embraced. But the idea is that the change process takes several different types of strategies. You need to improve awareness, you need to improve motivation, you need to improve awareness first, understanding, motivation, and then behaviors, which is skill-based. And obviously, the more you know about the person that you're providing services to in terms of what matters to that person, how that person thinks about things, what motivates that person, what that person's desire is in terms of the ultimate outcome, is the degree to which you will be successful in navigating that individual change process across those various stages of awareness, understanding, motivation, and behavioral aspects that need to be modified for the improved health status to actually manifest itself. Okay, if you can do those 5 things, it means that you'll be an effective healthcare provider, but it really does require good instincts about culture. It doesn't require any healthcare provider to be an expert in the cultural orientation of the person that he or she is providing services to, because it's impossible to be an expert in that person's individual culture. But if you have good instincts, you understand your own culture, and then you proceed in a way cautiously to make sure you don't disrespect that individual's cultural orientation, then you have the ability, and you have that strong relationship, and you build that trust, then you have the ability and probably a high likelihood of actually improving the cultural, improving the outcome that the service recipient really wants to achieve and actually attaining that outcome. Not improving it, but actually attaining that outcome. So bottom line, effective healthcare provides facilitating change in an individual. So you must know who the person is, what's important to that service recipient, how to deliver services in a way that are congruent with that person's expectations and don't disrespect cultural values. And the ultimate outcome has to be something that's congruent with what the person who's receiving services really is seeking. In order to do that, you have to understand that person's individualized culture. And so therein is the importance of culture for a healthcare provider in terms of being able to provide effective healthcare services. So now, in the world of cultural competency and providing culturally effective and culturally efficacious services, there are several tools out there, and I just want to take a minute now and talk about a tool that I developed some years ago. That's a tool, it's basically an interview prompt, and it's called the 3-dimensional model tool, because oftentimes the tools you see in the literature are tools that really either will have the clinician, the healthcare provider, to evaluate his or her attitudes or his or her readiness to provide services cross-culturally, and will sort of assess the clinician's readiness. You don't often find tools that really are designed for the clinician to build his or her own tool and then utilize that tool in a way that's specific to how that clinician provides services and matches that clinician's clinical orientation with the specific population of service recipients that clinician works with. So the 3-dimensional model tool is a tool that evolved several years ago. Actually, it evolved and began to evolve for me in 1999 when I first was teaching a course in a graduate rehabilitation counseling program. And the course was called Cultural Diversity, Development, and Disability. And so it had 3 major components: cultural diversity, human development, and disability. And the disability piece is really all about adjustment to disability. And so this is a rehabilitation counseling graduate program. I was a faculty member during that time. And so this is a brand new course, the first time it had ever been taught. I was assigned to develop the course and then teach it. And this course served as the course at the time that was the course that addressed cultural competency and cultural matters for the curriculum for that degree program. And so in thinking about the course, I was thinking, okay, but, this is a course that's really broad. It's got these three big dimensions: cultural identity, disability, and human development. And it could be a great survey course because you could really talk about those three concepts in a broad kind of way. And at the end of the course, the student really didn't have anything other than sort of a survey of what those three dimensions are. So I was seeking to have a culminating experience for the student in the course, for the student to leave the course with a tool that was beginning to be developed by the student, that the student could then take beyond the course and further develop and pilot test and refine and use to actually improve his or her clinical practice as a rehabilitation counselor, providing clinical services to persons with disabilities. So that was my goal. So the three-dimensional model tool came to me as a way to do that within that particular course. So the tool, as I said early on, is an interview prompt. And the tool is designed for each clinician to develop his or her own tool that allows him or her to have a certain way, a certain set of questions to explore who each individual is they're providing services to, who those people are in terms of cultural identity, human development, and what that person's ideal adjustment to their disability is. In other words, what's the outcome they're seeking from the services. And so the tool, in my mind, had to be theoretically grounded, because tools typically are, interview tools that are used in a clinical setting typically are grounded in theory, or at least have some conceptual basis in terms of why you're asking specific questions. So this tool needed to have that kind of orientation, theoretical grounding and anchoring. And it needed to address these three areas: human development, what the person's adjustment to disability is, and who the person is culturally in terms of cultural identity. So the idea is that each person will have to go through a process of exploring these three dimensions from a theoretical perspective and figure out which theories of cultural identity, what theories of human development, what theory of adjustment to disability really resonates and is intuitive to the student or the healthcare provider. And then they got to think about, does that theoretical orientation apply to the service recipient that he or she would typically provide services to, so the population they're going to work with. So if it passes those two screens, in other words, it's intuitive and makes sense to the healthcare provider who's developing this tool, and it makes sense in terms of being applied to the population of persons who it's going to be used on, then that becomes a suitable theoretical orientation. And then the idea is that the person then uses that theoretical orientation to decide which questions are the questions that are important to explore in terms of human development, in terms of cultural identity, in terms of what the person's ideal adjustment to disability really is. And those questions have to emanate out of those that theoretical basis that you have for each of those three areas. And then those questions become the questions that comprise that interview prompt. And the idea is that the person is developing this interview prompt in a way that would be congruent with his or her own counseling style or clinical orientation, or the way that they provide services. And of course that differs. Some people provide services as healthcare providers in different ways based on the approach they typically use and how they approach the process. And so the tool needs to be congruent with the provider, and it needs to apply to the population of persons that it will be used with. And then the third piece is that once the tool is developed, in other words, there's a theoretical anchor or foundation for each of the three areas, and there are a set of questions that naturally emanate out from those three theoretical foundations, then the person has to think about drawing a picture of the tool, because I am a strong believer that when you're using your tool has to be a part of you. It has to be second nature. It can't be a tool that where you are tied to a set of questions written on a sheet of paper to prompt you to know which questions you need to ask the consumer of services. You have to have the tool in your head at all times. So I told the students they were required to draw a picture of the tool, and to draw a picture or graphically represent it in a way that was meaningful to them, that helped them to recall it. And I was basing that on the work of Rudolf Arnheim, who wrote a book in 1971 was the first edition, called Visual Thinking. He was a neuro linguist or something like that. And his premise is that for people who are sighted, people who are in the seeing world, a lot of the recall is visual. That we tend to recall things in terms of pictures if you're sighted. Now, if you're not sighted, if you've been blind from birth, that's a different matter. But for people who have vision, a large part of their recall involves pictures. So I wanted the students to draw a picture of this tool so they'd be able to recall it and keep it in their mind's eye, so to speak, and have it with them at all times. And so the three-dimensional model tool really is a tool that's designed to have the student to be prompt to ask certain questions in the areas of cultural identity, human development, and what the ideal adjustment to disability is, so that the student or the clinician, when he or she uses it, will actually have a set of data that get collected on the service recipient, a new service recipient, that then forms the basis for that person having, the healthcare provider, having enough knowledge about the person in those three areas to actually have the ability to put together an effective treatment plan that will likely be efficacious in helping that person get to where he or she wants to be. And so to me, it was very important to have those three dimensions in the tool. Who is the person in terms of cultural identity? You got to know who the person is culturally, how that person's developing, how that person's functioning developmentally, okay, where that person is developmentally, depending on what theory you're using, and what that service recipient is looking for in terms of the ideal outcome of the healthcare services that you're providing. If you have data on in those three dimensions, those data come from the service recipient based on the questions you ask, then you have the raw material that you need to actually put together a game plan, i.e. a treatment plan, that's likely to be efficacious in terms of moving that person to where he or she wants to be in terms of the ideal outcomes of the healthcare endeavor, the services that you're providing. So that's a three-dimensional model tool, and it was published. I published it a couple times, initially in 2006 in a peer-reviewed journal. It was published again by myself and co-authors in 2 book chapters, and it has been published and referenced in several other journal articles and book chapters by the field, by academics in the rehabilitation counseling field. So it's out there, it's a tool, it's a tangible tool, it's concrete, and the beauty is it's theoretically grounded, it's constructed and developed by the clinician. So each clinician's, my three-dimensional model tool is going to look different from the next person's, because the tool is developed based on how I understand those 3 dimensions theoretically and who I'm going to apply the tool to in terms of population of persons with disabilities or persons with a medical impairment. It doesn't have to be a disability. So each tool is unique to its user and its creator, but the idea is that it doesn't matter what you ask, but you have to have a systematic and intentional process of probing the client and collecting data in those 3 domains: human development, cultural identity, and what the ideal adjustment disability is. And if you have data that you systematically and intentionally collected, that's theoretically grounded in terms of how you collect the data, that's in your mind's eye, then it allows you to achieve a body of raw material that speaks to who this person is in those 3 dimensions, that then will enable you to put together a treatment plan that's likely to be efficacious because it matches who that person is in those 3 dimensions. So that's the three-dimensional model tool. I encourage you to take a look at it. I can make available the article in the book chapters that I have as well. So with that, I think I will switch over now to the second part of our format, which is the question and answer and discussion and engagement. And again, thank you for listening for the first segment. And now let's embark on seeing what comments and observations and questions that you may have. Thank you.